Okay, so this slide's on cardioversion. I just want to mention one other topic about the previous slide. So what I was talking about was hands-only CPR, okay, where you're not giving those rescue breaths. So in an adult or a teenager, that would be appropriate because most of adult cardiac arrests are from the heart stopping primarily. That wouldn't apply to a child, though. Most children have cardiac arrest because of a breathing issue. So, for example, they choked on something and then went into cardiac arrest, or they had a partial drowning and then went into cardiac arrest. So, we don't do hands-only CPR with pediatrics. Uh, but in adults, the focus is on the chest compressions and not the breathing. So hands-only CPR has been shown to be as effective as CPR with breaths. So where you're doing 30 compressions, 2 breaths, 30 compressions, 2 breaths. Hands-only CPR has been shown to be equally effective because you're maintaining perfusion to the brain and not stopping the compressions. Okay, so cardioversion. So you've heard cardioversion mentioned in this module and you've heard defibrillation. What's cardioversion? So both cardioversion and defibrillation are basically we're putting electricity through the chest. And why are we doing that? We want to reset the electricity of the heart and hope that by doing so, the rhythm returns to a more stable rhythm, such as normal sinus rhythm, which is totally normal, right? So the difference between the two is just one aspect. Cardioversion, so the machine is doing this, by the way. So if we set the dial to cardioversion, okay, we choose the amount of electricity we want to put through the pads into the patient's chest. But cardioversion is when we press the button to deliver the electricity. Notice the bottom image there, there's arrows that are picking up the QRS. That's the machine doing that. That's the defibrillator or the cardioverter doing that. And it only does that when we've put it on a cardioversion setting. And the reason why is that is exactly where the electricity is going to hit um, uh, the heart during the electrical cycle. So when we push the button for cardioversion, it's going to land on a QRS. Okay. Why do we care? Well, we care because at the beginning of this module I mentioned that the T wave is a very sensitive time of the electrical cycle of the heart, the repolarization of the ventricles. So if we don't choose cardioversion setting and the patient has a rhythm with a T wave, which is lots of rhythms that we've done, most of them actually do have T waves. Well, if we don't choose cardioversion, the electricity is just going to land whenever we push that button. It's just going to land wherever, and it could hit the T wave. When electricity hits the T wave, it can put the person into an even more dangerous rhythm. So say they were in atrial flutter or atrial fibrillation, which are typically not deadly, and we didn't choose cardioversion, we used defibrillation, and the electricity hit the T wave, it can put them into a form of ventricular tachycardia called torsade de pointes. Okay, much more dangerous rhythm and can often be deadly. So we choose cardioversion so that the electricity is only going to be delivered on one of those QRSs, which is a safe place to deliver electricity. Okay, so that's the whole reason for cardioversion. If you have a T wave, we're going to use cardioversion. Okay, so if there's time, what we'll do is we'll prepare the patient. So they say this is an elective cardioversion. Someone's coming back after 6 weeks. to cardiovert atrial fibrillation? Well, okay, don't eat for 4 to 6 hours before arriving. We can sedate you. We can give you something for pain so you don't recall this event. You may have to withhold some medications, such as digoxin or other cardiac medications, and we're going to cardiovert you, right? We always clearly state that at the time of cardioversion, we ask everyone to clear away from the bed, okay? 3 times, clear. And typically, we also look around the bed to make sure that no one's leaning on the bed, right? Because you can transmit the electricity to one of the staff. We press the we press the button to release the electricity, and it will land. So the electricity will land right on a QRS, which is typically a microsecond away from when you pressed the button to release the electricity. Okay, so that's the difference between cardioversion and the next one called defibrillation. Okay, so defibrillation we're going to use in rhythms that typically don't have a T wave, right? And also in rhythms that don't have a pulse. So ventricular fibrillation, well, that's just a bag of worms in the ventricles that are just fibrillating. There's no pulse, there's no cardiac output, there's definitely no T wave. Pulseless VTAC, so we treat pulseless VTAC like ventricular fibrillation, and we use defibrillation, right? There's no pulse, there's no blood pressure, and we use defibrillation, okay? So that's really the difference. I know it says not used on conscious patients. Neither of those rhythms above would be a conscious patient. They wouldn't have a blood pressure and they wouldn't have a pulse, right? We still do the same thing. Now, typically, when we're defibrillating someone, they're not awake, so we don't need to give them sedation or painkillers. We can just put the pads on that you see in the upper right. Sometimes we sandwich the chest. We do one pad anterior and one pad in the back, posterior, or we do right upper chest and left lateral chest. Okay, either one. And we shout clear 3 times. We check around the bed, make sure no one's touching the bed, and we defibrillate. Okay. And when you looked at those algorithms on those slides for ventricular tachycardia or ventricular fibrillation, that's what we were doing, right? It was CPR for 2 minutes, defibrillate. CPR for 2 minutes, defibrillate. Add in some epinephrine, and then do 2 minutes of CPR, defibrillate. Okay. Let's move on from here. So just the slight differences. Remember the cardioversion. Why? Person has a T wave. Defibrillation, no T wave, no pulse. So at the top, we're seeing cardioversion. The person lying on the bed looks much too happy for a cardioversion. But often what we do, say someone comes in for an elective procedure such as to cardiovert atrial flutter or atrial fibrillation. We'll sedate them, we'll give them painkillers, IV of course. They'll sign a consent form that they're aware of the procedure. And then we do what's called synchronized cardioversion. What's it synchronized with? The QRS. The electricity is going to land on a QRS. Okay? And then of course we look at the monitor to see if we've managed to get them out of atrial fibrillation or atrial flutter or whichever rhythm we're cardioverting, and they've gone back into normal sinus rhythm. Compared to the lower right, which is defibrillation is usually just an absolute emergency, right? VFib or pulseless VTAC, there's absolutely no cardiac output, patient's unconscious with no blood pressure, and we're just going to send electricity right through the chest, okay? So it's still the same kind of electricity, We can choose the amount of electricity in both defibrillation and cardioversion. It's just that difference in terms of the cardioversion is not going to land on a T wave if the patient has a rhythm with a T wave. Defibrillation, there are no T waves, right? Pulseless VTAC, ventricular fibrillation, there are no T waves. So we don't need to worry about it. We can just send the electricity straight through. Okay, so let's change gears a bit and just talk about pacemakers. So typically, a pacemaker is used because someone has a very slow heart rate, right? And we want to use the pacemaker to stimulate the myocardium to beat faster. So if someone has a severe bradycardia at a heart rate of 30, well, that's going to create pretty low cardiac output. So we can use a pacemaker and choose the setting where we can choose, say, a heart rate of 70 or 80. Okay, so, and then to increase cardiac output. So two types of pacemakers. One is the temporary one that we've spoken about before, a transcutaneous pacemaker. So someone comes into the emergency room, they have a 3rd-degree block, their heart rate is 27 or 25, they have decreased cardiac output, their blood pressure is 80 on 50, they're semi-conscious, and we need to pace them. Okay, so we put the pads on that you see in the upper right corner here, and we set the same machine, so the same machine that defibrillates and cardioverts, we can put it on a pacer setting. So, so we set the machine to pace. Now we have to choose how much electricity do we want to put through the chest in order to what's called capture the ventricles and stimulate them to contract. So we increase the electricity. Remember, as we increase the electricity for pacing, it's going to hurt the patient. More and more electricity is going through the chest. And really what we want to see is that after the pacemaker spike that you're seeing on the rhythm strip there, that we create a QRS, and that's called capture. Okay. So otherwise, if there's just a pacemaker spike where the electricity went through, but there's no QRS, it means that it didn't capture the ventricle to depolarize. Okay, so we have to keep on turning up the electricity until we see capture of the ventricles. And we choose the heart rate. So we're turning up the electricity, we're turning up the heart rate to where we want it, and then if there's time, we'll give the patient something for pain, because this is going to hurt a bit, right? And it's going to make their chest contract at the setting that we chose for the heart rate. So if it's 70 beats per minute, their chest is going to contract. Their pectoralis muscle is going to contract at 70 times per minute. So often they need something for pain, they need a bit of sedation. This is uncomfortable, okay? And it's temporary. All we're trying to do here is maintain cardiac output, get those ventricles to contract, since, say, they have some kind of a heart block where the ventricles are contracting at 25 or 30 per minute, and it's just not enough. And we want them to contract at 70 or 80 per minute. So, so we're using a transcutaneous pacemaker. Okay. So let's look at the image at the bottom again, the bottom right. So that little vertical spike where you see those red arrows, that's actually the electricity from the pacemaker. And there's full capture here because after every pacemaker spike, there's a QRS, which is ventricular depolarization. Perfect, right? That's exactly what we want. And really this is just to get us to a permanent pacemaker, which may be later that same day, or again, if it's 3 in the morning, it might be early the next morning, okay? All right, now there's many different types of pacemakers. Some are in the atrium, some have leads going to the atrium, sorry. Some have leads going to the ventricles when we're talking about permanent pacemakers, okay? We'll have a slide on a permanent pacemaker. So just so you know, the temporary one is just to get the person to have their permanent pacemaker implanted. Okay, so it's just a bridging because they're unstable. Okay, so a permanent pacemaker placement. So on the slide earlier, we saw a transcutaneous pacemaker, just with the pads, and we're just going right through the chest with electricity to pace them. Permanent pacemaker is typically, again, put in for some kind of severe bradycardia, and often it's due to some kind of heart block. So if you go back and look at a third-degree heart block, you're going to see they're very bradycardic, very slow, right? Because the ventricles in a third-degree heart block only beat at 25 to 30 per minute. So usually it's some kind of severe bradycardia. They're implanted in the left upper chest. Okay, so they have to open up the tissue in the left upper chest, form a little compartment to insert the battery pack and the pacemaker, and then they have to feather the lead into the subclavian artery there, the left subclavian, and get it into the heart, whether it's the atrium or the ventricle, and it has to actually attach to the inner, to the endothelial layer, right? And it sends a signal through that lead or through that wire, and it will send a signal and cause a depolarization, which then causes a contraction. What are the complications? So, well, any procedure, there's always a risk of infection, right? Any procedure, there's always a risk of bleeding. Because they're right above the lungs, there could be a puncture of a lung leading to a pneumothorax. And because the lead, they're feathering this wire into the heart, if they're touching the sides of the chambers of the atrium or the ventricle, it can throw off some arrhythmias. Okay, so they're not usually permanent, they're just temporary arrhythmias while the lead is being inserted. Okay, so preoperatively, the patient's going to receive information about the placement of the pacemaker, the complications of the pacemaker, and of course, a consent signed is formed. A consent form is signed. Post-operatively, well, we're going to monitor. We're going to put the patient on a monitor, right? We want to see that this pacemaker and the lead going into the heart is actually capturing, right? It's forming a electrical stimulation of, say, the ventricle and leading to a contraction. So we want to monitor the heart rate and the rhythm. We want to check their pulse and their blood pressure, right? Analgesia, because of the procedure for sure. Minimal shoulder movement of the left arm. Remember, when this has been put in, everything is loose at the beginning. The pacemaker, the wiring. So patients can't just go home and put their arm over their head to scratch their back or to comb their hair. So minimizing shoulder movement with a sling. Okay, and that's going to go on for weeks. Okay. Monitoring for bleeding, so there could be a hematoma that forms under the tissue. That would show up as a big bulging of tissue where the pacemaker's been inserted. Infection would present as a red tender area where the pacemaker's been inserted, or they could present with sepsis if the whole line's become infected and now the blood has bacteria in it. Okay. The hiccups would occur if that line that's been put into the heart, remember, right below the heart is the diaphragm. So if that line somehow goes through the myocardium and touches the diaphragm, it can lead to chronic hiccups. Okay, so someone who has a pacemaker and they have persistent hiccups, we're going to think of whether there's a chance that the pacemaker wire is stimulating the diaphragm. Okay, so pacemaker patient education. So whenever someone gets a pacemaker, they get an identification card. Thank goodness, because there's so many different types of pacemakers We really need that card to see exactly what kind of pacemaker they have. It's going to have a number on it. We can call the company if we need help with figuring out their pacemaker. So very useful for that ID card. Restricting activity for 2 months is important, again, because you want to let that pacemaker and the wiring heal and form a very strong bond with the body and not get loosened, right? Avoiding direct blows to the pacemaker site, okay, that would be pretty clear. Avoiding powerful magnets or putting magnets over the left upper chest. It can deactivate the pacemaker, okay, so we're careful not putting magnets over that area, okay. Always letting healthcare providers or staff know that, oh, by the way, I have a pacemaker, okay? Because we don't always see that little pacemaker spike when we do an ECG. Most of the time we just see the lump in their left upper chest where the pacemaker is, okay? Because the pacemaker spike can be really, really tiny. They're not always really obvious. And then, of course, informing airport security that the patient has a pacemaker. Okay, so again, it's to avoid magnets. Okay, an implantable cardioverter / defibrillator. So who gets to have one of these? So typically, these are like implantable bombs in the left upper chest, right? So this device is going to monitor the heart, and it's going to monitor it for dangerous rhythms, such as ventricular tachycardia or ventricular fibrillation. So who gets to have one of these? Well, somebody who's had one of these rhythms and survived. So somebody who's had ventricular tachycardia, and there's quite a few people that will survive ventricular tachycardia for sure, or ventricular fibrillation, and there's a small percentage of people who've been lucky enough to survive VFib. Well, because they've been shown to go into these rhythms, they will be offered an ICD. And the ICD will monitor the heart continuously 24 hours a day and can send a shock to the heart if it detects VTAC or VFib. So these devices will go off at home. They could go off in your sleep any time of the day if the device detects VTAC or VFib. Okay. Now, the image on the left is really just a temporary ICD. So it's a vest while you're just waiting to get your permanent ICD. In terms of management of this, so again, preventing infection, helping the patient cope with this, because really it's like having an electrical device in your chest that could go off at any time that you get these dangerous rhythms, right? Now, if this device were to go off at home because it detected a dangerous rhythm, such as VTAC or VFib, the patient is still advised to go to the hospital. And these devices have memories. They can be looked at, and the rhythm that occurred at home can be examined to see if it was VTAC or VFib. And typically it is, because these machines are very accurate. Okay, so the patient doesn't stay at home if this device has gone off, and typically they wouldn't anyways, because it's pretty anxiety provoking having this electrical device in your chest, and then it's delivered electricity to the heart. Okay, so it's kind of an upsetting event for that to happen for someone. Okay, so let's just summarize this a bit. So arrhythmia / dysrhythmia treatments. So we often say electricity is the best medication. Okay, so if someone comes in a dangerous rhythm, such as VTAC, sure, we have the choice of giving them procainamide or amiodarone IV, or we can just say, no, this is dangerous. Let's just go right to electricity. Okay, so electricity really just tries to reset the whole electrical circuit, and it takes a second to deliver it, right? So unlike drugs that can take 20, 30 minutes to administer and drip in, okay? So let's just look here. Someone with severe bradycardia, so a 3rd degree heart block, or a Mobitz type 2, a Mobitz 2 2nd degree heart block, well, they need a permanent pacemaker. Temporarily, sure, we can give them atropine, or we could stimulate their heart with epinephrine or dopamine. Okay, AFib, A-flutter, supraventricular tachycardia, ventricular tachycardia. We could choose to cardiovert any of those and just get the person out of that rhythm. With SVT, we could use adenosine, right? Adenozine's only for SVT. With AFib or VTAC, we could try an amiodarone instead of cardioversion. It's not unreasonable, since in AFib, the person's typically stable. In VTAC, with a pulse, we would typically, as I mentioned before, go right to synchronized cardioversion. Okay, pulseless VTAC, ventricular fibrillation, we're going to go right to defibrillation, right? We can still administer epinephrine while we're doing CPR for 2 minutes, and then defibrillate, and then CPR for 2 minutes, and defibrillate. We're giving epinephrine, and we can also add amiodarone into the IV during that protocolized sequence of CPR and defibrillation. Okay, so let's look at a couple of rhythms here. A patient with mitral stenosis exhibits new symptoms of a dysrhythmia or arrhythmia, right? Same thing. Which heart rhythm would the nurse expect to see? Well, let's just look at these rhythms first. So the first rhythm, so let's just ignore the question and look at the rhythms, and then we'll come back to the question. So the first rhythm there is basically just a bag of worms squiggling in the ventricles, right? There's no organized QRSs. It's not ventricular tachycardia because it doesn't have nice, consistent QRSs that are going super fast. So this is ventricular fibrillation, okay? This person needs CPR, defibrillation, CPR for 2 minutes. Defibrillation, CPR plus epinephrine. Defibrillate, CPR, okay, let's add in some amiodarone, okay, that sequence. The second one, there's a P wave and a QRS, and then a P wave and then a QRS, and okay, this is sinus rhythm. Okay, so I ask myself, is it slow, normal, meaning 60 to 100, or fast? Well, this one's slow. This is sinus bradycardia. Okay, if you wanted to figure out how slow, let's start with the first QRS. So it happens to land right on a bold pink line. Okay, and we'll go over one bold pink line. If there was a QS there, it would have been 300. Go over again, 150. Go over again, 100. 75 is the next one. 60 is the next one. This is into the 50s, right? So this is 50 something. So this is slow. It's sinus bradycardia. Third one is asystole. Patient's unconscious, no pulse, no blood pressure. Bad prognosis. CPR and epinephrine for that. Last one is, I can see QRSs. Do I see consistent P waves before the QRS? No, I don't see consistent P waves. Some of them I don't see anything in front of the QRS, like before the QRS, and it's really irregular. Okay, so this is atrial fibrillation. So this would be the answer to the question. So what happens in mitral stenosis? Well, the blood can't leave the left atrium very easily. So it causes distension of the left atrium. And when you stretch an atrium, you're stretching the nerves of the atrium, and often that can lead to atrial fibrillation because you're irritating the nerves of the atrium. Just like left ventricular heart failure backs up blood into the left atrium, and then of course it backs up into the lungs. But those patients often go into atrial fibrillation as well because of the backup of blood into the left atrium. Okay, so here's the answer, atrial fibrillation. So it's irregular. So what's irregular? The QRSs. So if you were to feel this person's pulse, it would be beep, 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 beep. It'd be totally irregular. Okay. When we look at the rhythm strip, we can see that the QRSs are not timed at all, right? And there's no P waves before the QRSs. There's just these squiggly lines before. I mean, some of them you might be able to say, oh, I think I see a P wave, but they have to be consistently before every QRS. Okay, so it's irregular and there's no P waves. It's atrial fibrillation.